Welcome to H&HN Daily. I'm Suzanna Hoppszallern, Senior Editor for Hospitals and Health Networks magazine. The patient-centered medical home is a healthcare setting that facilitates partnerships between individual patients, their personal physician, and when appropriate, the patient's family. Care is facilitated by information technology and health information exchange to assure that patients get the indicated care when and where they need it and want it in an appropriate manner. Today, I'm joined by Dr. Donald Lurye, CEO of Elmhurst Clinic in Illinois, to discuss evidence-based medicine's role in the medical home. Welcome.
Thank you.
Thanks for joining me today. How can the patient-centered medical home be evidence-based?
Well, you really have to marry three things: culture, technology, and evidence. You need, first of all, a team-based culture where there's a common recognition that everybody has a role to play in patient care. The physician directs the team but is supported by staff, possibly other clinical staff and social workers, or whatever types of services are needed in your community. And so you then use technology, typically an electronic health record, to organize information, organize the evidence. You can then use staff at varying levels of licensure to implement various pieces of that evidence in a very comprehensive manner, so that a patient who presents with, say, a sprained ankle, well, we don't lose an opportunity to take care of the diabetes and hypertension while they're there, because our electronic health record presents that evidence to us in a way that's easy for someone to access and understand, and doesn't necessarily have to be the physician. So if there's some testing that's needed, or a diagnostic study that needs to be scheduled, that can be done before the physician sees the patient. That then allows the physician to focus on applying, the years of training and clinical judgment to the specific presenting problem, and can take into account the nuances of the patient's individuality, however you define that. And it's a matter of budgeting time and letting the right people do the right things within the context of this team-based care.
How do you individualize the care to the patient's preferences? Can you give me an example?
Well, this is actually, in the area you're hitting on is kind of the new frontier in clinical guideline development, that the concept that the patient's preferences should be taken into account as part of the evidence that you use to design a care plan. Probably the best example comes from the world of cultural competence, where you have people with varying languages and cultures that, if they're not seeing a physician who's familiar with their language or culture, can really go right by each other. And particularly dietary habits and differences between cultures can make it very difficult to manage something like diabetes or lipid disorders. So to the extent that the patient, comes from a culture that eats a lot of foods that the physician might think aren't good for you, well, how do you modify that diet? How do you adapt it in a way that at least minimizes the impact without and preserves the patient's way of life and the family that surrounds that patient?
And are we seeing better outcomes with diabetics using this patient-centered medical home?
Yeah, there are examples, and they're published, of where it's clear that at least the metabolic outcomes of diabetics have been better, and by that I mean changes in the numbers that we usually measure. Very recently, the PCPCC, I believe that stands for Patient-Centered Primary Care Collaborative, published online a summary of a large number of studies of various medical home models demonstrating improvement in clinical outcomes and improvement in utilization and cost measures as well.
And how can it affect the cost measures and reduce the cost of care? Can you give us an example?
Well, probably the best example would relate to follow-up after hospitalization. If you are clear that there's an appointment made, the patient knows when it is, has the means to get there, and the hospitalization information has been transmitted to the primary care physician, then you have a much greater chance that any early complications post-hospitalization will be spotted, will be dealt with quickly, not resulting in a readmission.
So you already have this health information exchange set up with some of your key providers of care?
Well, we have it internally to our electronic health record. A next step in our community and many others is to be able to link up information among physically and disconnected providers who don't habitually work together. That's really what you're referring to, and it's a great next step. It's sometimes called a medical neighborhood, by the way.
How has this patient-centered medical home affected patient satisfaction and family involvement in the patient's care?
Yeah, that's a really good question. I have to say we haven't directly measured that. I can tell you that over the past 3 or so years, our patient satisfaction scores have gone up. And I can't definitively attribute it to being more organized, but if you, in our survey, if you look at the written comments section, there's talk about, well, the doctor always seems to know what's going on. If you look at the physician-directed questions, it's, knowledge of my history always gets a pretty high score. Respect for the patient and the family always gets a pretty high score. And, to some extent, that's because we've created an environment in which physicians aren't spending time running around looking for stuff that should be sitting in front of them.
Thank you for joining me today.
It's been my pleasure. Thank you.